One, two, one, two, one, two, one, two on the mic. Is this thing on? Y'all know we're not just in a healthcare crisis anymore. We're headed towards a full-blown crash probably within the next few years. In 2024, healthcare bankruptcies hit a 6-year high. Of that 6-year high, there were 10 clinics and physician groups involved that had 10 million in liabilities each. Why? Because they're following outdated financial models just like the banks before the 2008 crash. And just like them, they're ignoring the warning signs, they kept doing business as usual, and then the banks got wiped out. History is definitely about to repeat itself, but this time it's in healthcare. The question is, will your medical practice survive a crash if it comes? The 4 risk indicators that I'm about to share with you in this video are the same financial warning signs banks ignored before the Great Recession. If you don't take these seriously, your practice will be next. My goal with this video is to wake up as many medical practice leaders as I can, give actionable insight that can help you evaluate your financial survivability and start having discussions with your team, as well as take some action immediately. Hi, I'm Talitha, a former RN with 20 years experience turned practice management change consultant. And I help private practices go from task-driven to outcome-focused so that their team can anticipate challenges, help the organization improve its patient care, as well as help you build a thriving practice in today's unpredictable healthcare landscape. So if that interests you, make sure you hit the like button, don't forget the notification bell, and make sure you subscribe for new videos every single week. So before we break down these 4 risk indicators, let's rewind to 2007. The banks thought everything was fine. Their models were safe. Then the crash happened. And now the healthcare industry is walking the same exact path. History is repeating itself, but this time it's your practice on the line, not the banks. If we fail to learn from history, we are doomed to repeat it. And if you do not shift your practice now, the same collapse could happen to you because it is not set up for the little guy to end. And we'll get into why here in a second and the specifics of it. So I'll give you a little bit of background history first, then I will connect history to present, and then we will discuss the #1 threat to small and rural clinics. Then we'll dive deeper into the rest of the risk indicators, giving you a few tips along the way. But by giving you a little bit of the background context first, you'll be able to take this information, evaluate your own medical practice, and then take the necessary steps forward towards stability. So let's jump right into the meat and potatoes with a little bit of background info first. Let's break down exactly how healthcare is similar to the financial system and how they are on a direct course to a crisis crash. So I have been reading this amazing book called Outlive, and in Outlive, they point out that back in 2007, many decision makers believed the housing market was stable largely because they were relying on historical trends and risk models that had worked well in the past. So home prices have been steadily rising for decades, and default rates on mortgages were low enough that models assume a continuation of this pattern. In other words, before the 2008 crash, banks claimed they were managing risk well while still approving risky subprime mortgages under the old assumption that home values would always rise. The financial institutions' analysis were built on historical data that showed a robust market with little indication at the underlying credit quality, especially among subprime borrowers, were deteriorating. What was missing that prevented them from seeing that, however, was a more granular set of quantitative risk indicators, key data that would have revealed the mounting systemic risk. Similar to today's time and age, where I feel like we are relying on a lot of qualitative data instead of quantitative data. So the 4 risk indicators include risk concentration, leverage and liquidity ratios, stress test scenarios, and correlation data. So let's talk about the first of the 4 risk indicators, risk concentration. Risk concentration metrics are quantitative measures that assess how much of a portfolio's overall risk is tied up in a single asset or asset class or specific risk factor, like subprime mortgages, for instance. So the institution becomes more vulnerable to adverse events affecting that specific segment. Banks before 2008 had one major flaw. They were too dependent on risky mortgages. When the market shifted, they collapsed. Private practices today, they're making the same mistake. They're too dependent on insurance reimbursements. If those get delayed, reduced, or denied, what happens to your practice? Because its income is concentrated in one revenue stream. The practice faces significant financial risk similar to a bank suffering a downturn in its concentrated asset class. And then that's the key issue. Insurance companies are shifting toward a value-based model where physicians are expected to improve patient outcomes in order to be reimbursed fairly, but they're still reimbursing based on the outdated fee-for-service model. This creates a fundamental contradiction, much like how the banks before 2008 expected to manage risk while still using flawed, outdated systems that incentivize to approve bad loans. So think about how the insurance industry currently works. Imagine a patient with a glucose of 137, which is high and out of range. The physician knows early intervention could prevent diabetes and reduce long-term healthcare costs for the patient and the industry. So he makes moves to do so. But insurance still follows the old fee-for-service model. They won't reimburse for treatment unless the patient crosses the 140 threshold, forcing the doctor to wait until the patient condition gets worse before getting paid. Outcome-based model contradicts reimbursement's current reality. The doctor is graded on patient outcomes, but is currently being paid based on reactive care, forcing them into a flawed system that currently does not actually reward prevention. Imagine your car brakes are wearing down. You see the warning light, but your mechanic says, come back when you crash. That's exactly what insurance companies are doing to doctors right now. They won't pay to prevent patient decline, only to treat the disaster afterward. And that's why the system is collapsing. This mirrors how banks were expected to manage risk, but were still incentivized to approve bad loans under the old system. Just like banks could have avoided the 2008 crash by correcting their models before the crash, insurance companies could prevent massive healthcare costs and the crash by aligning reimbursements with their value-based care goals now. But they aren't. And why is this dangerous for medical practice? Because physicians are in a no-win situation. They're being graded on patient outcomes, the value-based care system, but they're currently being paid for volume, the fee for service. If they focus on prevention now, they lose money because insurance won't reimburse them. And then they have to fight all these denials and appeal, which is more staff and money, right? If they play the fee for service game, their patient outcomes suffer, which they've known this for a long time. And they risk penalties under the value-based model. Insurance companies are expecting physicians to do something that the system is not even set up to allow them to accomplish. A result-driven practice relying solely on insurance reimbursements. Both banks and insurers expect professionals, bankers and doctors, to fix problems within a system that actively prevents them from doing so. They deny the tools that could actually prevent collapse and then respond when it's too late. And I guarantee you, local medical practices will be the most impacted. So if you plan on remaining an independent medical practice that wants to hold on to their autonomy and not get swallowed up by the local hospital system, or worse, get bailed out by private equity and closing in a few years anyway because you're being sold to the highest bidder, or you end up having to file bankruptcy with all of those liabilities and assets. You want to listen up and you want to take action immediately after this video and having major discussions in your team. Don't worry, I'm going to tell you exactly how you can do it. Because if there is a crisis crash and a government bailout, do you think your small organization would be saved? I'm sure many small banks thought the same, or at least hoped the same, back in 2008. Between 2008 and 2013, the FDIC recorded roughly 489 bank failures. Multiple analysis of that period have shown that the vast majority of these failures, often estimated between 80 to 90%, were among small, community-oriented banks that primarily served local markets. This means that on the order of 400 to 440 small banks went under out of the 489 during the crisis, in contrast to few very large nationally active banks. Many of them received substantial government support during this crash. They were recognized as too big to fail. So they were provided either with capital injections through the TARP program, had liquidity guarantees, or were forced into mergers arranged by regulators. If you are a practice leader and you work in a small clinic, comment yes or no below if you think that your practice would be saved. I'm just curious to know what y'all think. So whether you said yes or no, or whether you're unsure or not, let's continue to dive deep into these financial warning signs that show key data that would have revealed the mounting systemic risk and how it correlates to today to the healthcare industry, and what specifically you as a medical practice leader should be looking for in your own practice to see if you're at risk. Jumping directly into the second one, which is leverage and liquidity ratios. In finance, a leverage ratio measures how much debt an institution uses to finance its assets relative to its equity. For example, if a bank is highly leveraged, it means it has borrowed a lot of money compared to its own capital. While this can boost profits when things are going well, it also means that even the smallest drop in asset values can quickly erode its equity, making it vulnerable to insolvency. Liquidity ratios assess how quickly an institution assets can be turned into cash to cover short-term obligations. For banks, maintaining sufficient liquidity is critical because they must be able to honor depositor withdrawals or other sudden cash needs without having to sell assets at fire sale prices, basically discounted. So for a medical practice, you can think of the speed of reimbursement plus your reimbursements connected to your outcomes as your liquidity. It's important to make sure your practice is holding sufficient reserves to weather unexpected financial shocks, like a closure from a pandemic, for instance, a principle that can be directly applied to the management of a medical practice's cash flow. In medicine, just as in banking, it's crucial to understand not only your total revenue, but also the timing and consistency of that revenue and the regulations and the flows of it and the demands and the changes. If your practice is running smoothly today, you might think you're safe, but ask yourself, how many denied claims can you afford before your payroll is at risk? How many delayed reimbursements can your cash flow handle? And do my team know this? So let's look at denial to approval ratio. A lower ratio indicates that most claims are approved, ensuring a steady cash flow. A high ratio, more denials relative to approval, suggests that a significant portion of expected revenue is delayed or lost, which can strain the practice's ability to meet its short-term financial obligations. So then if you look at timeliness of reimbursement, if a practice gets reimbursed quickly, it means that cash is flowing in faster, much like having liquid assets that can be used to meet expenses. A longer turnaround on claims, meaning excessive denials or losing the appeal, mean cash is tied up, which is similar to having illiquid assets. Delays in processing claims, delays in scheduling, patients canceling all the times, patient not following proper pre-op setup. All of these can lead to cash flow issues as revenue streams become unpredictable. So just as banks' liquidity ratios would suffer if staff shortages slow down the conversion of assets into cash, a medical practice might struggle to meet its short-term obligation if it can't maintain its regular revenue cycle, which is why you want to make sure that you're not having staffing shortages. But how hard is that to do in the medical community, you know? But similar to banks, which maintain a liquidity ratio, a practice should hold a cash reserve to cover delays or unexpected denials. If historical data show that 15% of claims are denied or delayed beyond the typical window, the practice should maintain a reserve sufficient to cover the 15 to 20% of its monthly operating costs. If you're not even tracking this, you don't know what to cover, or you don't know how much you need to cover. By tracking these metrics, a practice can gauge its operational liquidity, essentially just as a bank would monitor its cash reserve and quick asset ratios. A medical practice can monitor the speed and consistency of its claim reimbursement to ensure it maintains healthy liquidity. I hope this is making sense. Is it making sense? Comment yes or no below, because I sound like I got really techie or analytical or something, and I just want to make sure you're with me. So if you're with me and this is making sense, comment yes below. Or if not, ask me questions. I am here to help clear this up and let's get some understanding. Okay, so the next one that we're gonna jump into, to me, is one of the most important ones, because it's basically like you're not just graded on your own merit and efforts to how you affect your patient's outcome anymore. You're graded on the doctor you referred them to. And in my opinion, on this new insurance model, it's going to be one of the most important, because this is the one in the medical field that you honestly have very little control over going forward, besides changing who you refer to. And that one is correlation data. Correlation data refers to the statistical measurement of how two or more variables move in relation to one another. In risk management, whether in finance or healthcare, understanding these relationships is critical because it reveals whether different risk factors are interconnected. In banking or investment portfolios, correlation data quantifies the degree to which two assets move together. It's usually expressed as a correlation coefficient, which ranges from -1 to 1. A coefficient near 1 means the assets move similarly, while a coefficient near -1 mean they move in opposite directions. A coefficient around 0 suggests little to no linear relationship. So a high positive correlation means that one asset loses value, the other is likely to lose value as well, reducing the benefits of diversification. Financial institutions use correlation data to ensure that their portfolios aren't overly concentrated in assets that will simultaneously suffer during a downturn. In the medical practice, you want to compare this to your physician referral network. In a physician referral network, on the new model, the quality and performance of each individual physician can be highly interdependent, much like correlated assets in a financial portfolio. Here's how you can think about it. Just as correlation data in finance measures how two assets values move together, in a referral network, you can think of patient outcomes as being correlated among the physicians. For instance, a primary care physician who accurately identifies complex conditions and refers patients to a well-performing specialist sets the stage for better overall care. It can improve outcomes for patients throughout the network. Conversely, if one physician in the referral chain is underperforming, say a specialist who frequently delays treatment or fails to follow best practices, the negative impact isn't isolated anymore. Poor outcomes in that one link can affect the entire chain, leading to increased readmission rates, complications, or even higher mortality. It's like a group project. No matter how good your part is, if your teammate fails, the whole project failed. If the network is weak, it pulls down the overall performance, much like a poorly performing asset in highly correlated portfolios. Now that insurance is moving to a value-based care model, your reimbursements are not just based off of your performance, but your interconnected performance as well. The value-based care model is about the patient outcome, their results. That one patient, did they get better? It's not about which physician got them there. And whether we want to admit it or not, caring for a patient is a whole body system approach. They themselves are interconnected. Because whatever medication one gives is going to affect the kidney, the heart, etc. We know this. And as a nurse of 20 years, and I'm sure you being a medical practice leader, let's not mince words and know and think and accept the truth of the reality that in many towns, there are doctors, hospital, physicians, clinics that you would not send your dog to. Now, as I say that, think about that as I go into this next section. Does that make sense? Comment yes below if you're following along. And let me know, has your practice looked at this specific risk indicator yet? Have you guys thought about that? Okay, so we've made it to the fourth and final risk indicator that would have warned the banks. Hopefully, it can actually help medical practices that see this and they can take action immediately and not end up like the banks. So the last one is a stress test. And no, it's not checking your heart. It is checking the heartbeat of your clinic. In finance, stress tests involve simulating adverse scenarios such as severe economic downturn to assess whether an institution's capital and liquidity are sufficient to withstand shocks. The idea is to proactively identify vulnerabilities and prepare contingency plans. Similarly, outpatient medical practices also face risks like sudden drops in patient visits, technology failures, remember CrowdStrike, supply chain disruption. Are you paying attention to the news? Staffing shortages. When have we not? And all of these can jeopardize operations. However, many outpatient medical practices mistakenly assume that robust emergency preparedness is solely a hospital responsibility. As a result, they do not conduct formal downtown procedures or simulate stress test scenarios like we did back in the day when we were on paper. There are no practice downtime procedures because they don't practice downtime in their technology, so they don't practice downtime anywhere else either. Bank stress tests for a recession. Have you stress tested your practice for at least even a pandemic closure? The 2020 pandemic should have been a wake-up call. Outpatient practices that had not planned for emergencies were left scrambled when routine operations were disrupted. They found themselves vulnerable to cash flow problems, disruptions in patient care, and operational inefficiencies, much like a bank that hadn't stress tested its portfolio against adverse economic conditions. And please, let's not act like it's not a possibility of it happening again. And the problem with that is most doctors just want to doctor, so they are really hands-off and had no idea that their practice was not ready. What happens if your top biller starts penalizing you without warning? If a major insurer delays payments by 90 days? If you lose 20% of your patient volume overnight? If you haven't run these scenarios, you're running on hope, and hope is not a strategy. By adopting stress test-like procedures, evaluating how quickly claims are processed under adverse conditions, assessing the impact of sudden revenue drops, or even practicing responses to technology downtime, medical practices can identify weaknesses in their financial and operational models. What would happen to your organization if a crash hit tomorrow? This proactive approach helps build resilience, ensuring that when unexpected challenges arise, the practice can continue to serve patients while managing its financial obligations and streamlining operations for the most efficiency and the best patient experience. The question is, will your practice survive it? Let's do a quick recap. Risk concentration. If all your revenue is tied to insurance reimbursements, you're one reimbursement cut away from a financial disaster. Diversify now. Leverage and liquidity. Do you know how much financial pressure your practice can withstand? If insurance delayed payment for 90 days, could you still make payroll? Track your cash flow and denial rates before it's too late. Correlation data. Your referral network isn't just collaboration. It's your reimbursement score. If the physicians you refer to are underperforming, it's dragging your payments down with them. Audit your network now. Stress testing if a crisis hit tomorrow. A billing system outage, a patient volume drop, a sudden reimbursement freeze. Would your practice survive? Run the numbers. Build your safety nets. Hope is not a strategy. So here's your next step. 1, if all of this was a lot and you want me to just send it to you in a nice little Google document so that you can start sitting down with your team this week, start assessing these risk factors now, comment proactive down below and I'll send it to you. You don't need to give me your email or anything. Just comment proactive. I'll send it to you in the DM. It's just a regular Google Doc, nothing's fancy schmancy or anything like that. And then I'm just gonna break it down, the next steps, what you can do, and then you can start having discussions with your team. So you wanna audit your revenue streams. How dependent are you on insurance? Do you have something you can sell for cash. Start tracking cash flow, denial rates, how long client claims take to process, and then connect those with penalized outcomes. Make sure your referral partners aren't dragging your performance down. Have you audited the patients you refer to them? Do you talk to your patients about their actual experience afterward? This is about more than running a smarter practice. It's about protecting everything you've built. It's about your staff. It's about your team. It's about your patients. Let's be real. This healthcare crisis crash is already unfolding. The question is, will your practice survive it? Like I said, only the most proactive will survive. So if you want me to send it to you, if you're ready, you need to start having discussions with your team, comment proactive below. I'll send it right on over. And if you know a practice leader who needs to hear this, send it to them now, because this crash won't come with a warning, but it will come with consequences, and lots of them. See you in the next video.